Plumas County Public Health Agency, growing healthy communities.
Hi everyone. So I'm really excited to see so many people in the audience. I'm not totally sure how this is going to go. My goal is to basically throw some stuff out at you that I've been thinking about, talk for no more than half of the time and hopefully less, and then give us some time to talk as a group about what resonates or what doesn't. So like Zach mentioned, I'm a researcher and a harm reductionist, so I do research, ethnographic research on opioid use and other drug use issues in rural communities as well as some urban communities in California, and I've also been involved in harm reduction work with people who use drugs for 9 years. So in this talk I'm going to draw both from my research as well as just from my various other experiences doing harm reduction. And building on what we talked about at the beginning, I want to sort of not only talk about what's great about cities that we should bring out to rural areas, but what's great about rural areas that we can learn from all over the place. So thank you. So I usually start talks with this slide because I think it's a picture that tells a story. So this is just a chart of overdose deaths over the past 20 years now almost. And as you can basically see from the chart, what started as primarily a prescription drug-driven overdose crisis has transformed over the past 5 years or so into one that's really being driven increasingly by illicit opioids and opioids that are typically injected, so heroin and fentanyl. And as a result of that, we're seeing some new health vulnerabilities in rural and remote communities in particular that we haven't been as concerned about in the past. So I want to just illustrate in a few different ways how the opioid crisis is differentially impacting non-urban communities. So if we're talking about injection drug use, we're worried about risk of HIV and other transmissible diseases through equipment reuse. And a few years ago, you might remember, all those fears were realized in Scott County, Indiana, when nearly 200 people were diagnosed with HIV in less than a year in a small county that had very little infrastructure to support a response to that kind of problem. And after that outbreak, the CDC did a vulnerability assessment to look at what other kinds of counties had similar risks as Scott County. They identified these 220 counties as the top ranked ones on their vulnerability index. And as you can see, almost all of these counties are non-urban. So they're in places that historically haven't had harm reduction, and that's one of the reasons they're at risk. You might notice that not many California counties are highlighted in this assessment, but that's in part because of how the CDC did it, the kinds of measures they used, and some California researchers are working on their own assessment that's going to show that vulnerabilities that look like this really do exist in large parts of the state as well. Taking another look at this, a similar kind of pattern shows up when it comes to overdose prevention. So this is a recent paper using data from 2014, so it's actually a little bit old by now, but it shows overdose mortality, so that's the coloring of the counties, and then the location of overdose prevention programs that distribute naloxone. And what these authors found is that only about 13% of US counties that are at the highest risk of drug overdose had these programs in 2014. And that those places that didn't have them were disproportionately non-urban. So you can see all of these blue counties, dark blue counties, where people are dying of opioid overdose, and a lot of them back in 2014 had no naloxone programs at all.
What is the red dot?
The red dots are the locations of naloxone programs.
Oh, okay.
So each red dot represents a county that has at least one program. This has changed, so Plumas County isn't highlighted on this map. That's because they founded a program in the last 4 years. Same with this whole little chunk of counties up here and a number of others in California. But historically, there's been a mismatch between the issues that remote counties are facing and the services that are available. Same kind of pattern holds if we zoom in on California a little bit. So this is data that compares these are really quick and dirty graphs, but the overdose rates by county compared to where you can get access to, in this case, methadone, so a narcotic treatment program. You can see that nearly all the counties with the highest overdose rates lacked access to that modality of treatment in 2016. And similarly, there's a mismatch, again, in infectious disease risk. So rates of newly reported Hep C on the left, you can see again, it's an epidemic that's primarily affecting rural Northern California. And a lot of those counties still do not have access to clean syringes locally. So that's really why we're talking about non-urban communities and trying, in some ways, to learn from urban communities, because historically that's been where harm reduction is happening. So I wanted to talk a little bit about harm reduction history. Harm reduction didn't start as a public health response. It started as a grassroots response of people who use drugs, who were facing the threat of AIDS, back when AIDS was a disease that killed you very quickly. So it was a life or death matter. It was initially illegal in California, which meant that groups had to organize underground. So on the left you see, it's a news photograph from Prevention Point, which was San Francisco's first syringe exchange program. It started in 1988. So what they had to do, because it was illegal, they hid a biohazard container inside a baby carriage, and they would walk through the park where people who use drugs hang out, essentially asking them to feed the baby with their used syringes and giving them out clean ones in exchange. So they did that work for many years until they finally started to receive some local government support. And since 2000, syringe exchange has been legal in California. But ironically, even though it's been legal since 2000, we've seen a lot fewer programs get started in the past 20 years than we did in the 10 or 15 years before that. So that's what leads to like the graph, like what we saw on the previous slide, of huge swaths of the state just not being served. A similar kind of pattern when we talk about overdose prevention. So again, something that started underground because people in public health departments weren't willing to do it. Something that we now know saves lives and connects people to all kinds of other services. So like we heard from James, overdose prevention training started in the late 1990s. Once harm reductionists noticed that the drop in AIDS-related deaths meant that overdose was becoming the primary thing that was killing people who use drugs. Naloxone distribution was initially underground. One of the great naloxone distribution programs in the world was started right here in California by Rachel McLean, who might be in the room somewhere. And so I love this quote from Rachel. You knock on lots of doors, and whichever opens you walk through. And I think that's just a good way to think about doing all this kinds of work, especially in rural communities where it might take working with an agency that might not seem like the natural candidate, but they have a good champion there who wants to work on the issue. So you make progress in however you can. So I wanted to talk about that historical background because even though these things started in cities, I think the same attitude and the same principles that animated early harm reduction are what we need to remember when we bring it to new places, even if those places look a lot different than the places that, than San Francisco and the Tenderloin. And it also means, I think, one of the things that I want to sort of reiterate throughout this talk is that sometimes it's better to, ask forgiveness than ask permission before you start something that you know works and that you need to put in your community to save lives. So just a little bit about my research that I'm drawing from. I've been working on this research for a long time. I've talked to a lot of people. And so what I'm doing is basically doing ethnography in multiple places. So hanging out with people in their everyday lives, trying to understand how they make decisions, why they do the things that they do. For me, that doesn't just involve the people who use drugs, but the people who are trying to design services. So what I've been doing is interviewing and hanging out with people, doing health services, substance use treatment, harm reduction, law enforcement in a bunch of counties, and then also spending time with people who are actively using drugs in a number of counties as well. So I'll be drawing from some of that research here. I want to stop and see if there are any questions, anything that wasn't clear in what I've said so far. I know I'm talking a little bit fast, so I'll try to take it too.
Can I just say
Please.
something? Hi, I'm Eloise from Glenn County. One of our just main issues, and one of the things I'm really interested in why I came, is on data collection. We have actually really poor data.
Yeah.
And that's like our first kind of project of our coalition is to get good data.
Data
to
on what?
understand the problem. Who, how many people are dying, how many people are having an overdose. If you have a medical emergency in Glenn County, the EMTs will tell you the first thing we're doing is getting you out of Glenn County. So we're going over the county line to the next door hospital, and it's just really hard to get good data.
What county?
Glenn,
Glenn, thank you.
next to Butte, close to Pema.
Yeah.
Getting good data.
Yeah.
Getting data reported, getting, death and overdose data from our neighboring hospital.
Yeah.
It's 20 miles away, but that's the reality, that we don't have access.
Yeah, you bring up a great point, and working across county lines is something that I would sort of like to touch on in this talk, and maybe we can talk more about. But data, yeah, if you don't know what the problem is, then it's really hard to convince anyone to do something about it. Yeah. Okay, great. So I'd like to start with just a little story, a little vignette from my research, to sort of illustrate what the reality is that we're talking about, okay? So imagine you're in your early 30s. You live in a small town in the same county that you've lived your entire life, same county that your parents lived in your entire life. Your uncles and cousins and most of the men in your family grew up using drugs, drinking, getting in trouble with the law. So every cop in the county knows your last name in a bad way. When you were a teenager, you were doing some work on the side, and you were maybe in some unsafe working conditions, and your back got crushed in a heavy machinery accident. And you never got any kind of good pain treatment for that injury, so you live to this day in chronic pain. Some days you can't even get out of bed or get up from your chair without help. Remember, you're in your early 30s. You started injecting pills after you re-injured your back about 10 years ago. A friend had pills. You needed them because you were basically immobile from the pain. They injected them. They taught you how to inject, and from then on you've been injecting pills basically without stopping. For a time you could get them from doctors in your town. Sometimes you had to go to a few different doctors. It might take you, a whole day to drive around and get what you needed. But a few years ago those doctors all decided to cut you off, either because you were using meth occasionally, or because you went through your pills too quickly, because it seemed like you were using too many of them. And so it's not like your pain went away. So as soon as you stopped using those pills, you started calling around and trying to find who in your town had heroin that you could use to stay well. So on a typical day, you wake up at 3 in the morning in excruciating pain. You've slept for 3 hours, and that's how long it takes before your withdrawal symptoms. So if you had any heroin left over the night before, you would have cooked up a shot, pre-filled it, and left it by your bed so that you could wake up, use it quickly, and fall right back asleep, and maybe get something approaching a full night's sleep. But you didn't have any heroin, so all you can do is rummage around, try to find, some cottons that might still have a little bit in them, call around to see if you have any friends who are up that late, see if you can get anything, because otherwise you're going to be awake the rest of the night. If you manage to get back to sleep, you wake up, say, 8 or 9, again sick, you immediately start figuring out how you're going to find heroin that day. You're going to call around to the 3 or 4 friends in town that use, that sometimes have a little bit they can sell, or that might be able to give you a ride or pool their money with you to get to a city over 2 hours away, where you have one connect that you might be able to get a good deal from, if you can get them on the phone. You're sick still, so before you leave, you again have to go through the process of scrounging through all the supplies you saved from the previous times you've used to find something to get you well, because 2 hours in the car, if you can't find anything, you're going to be pulling over every 10 minutes to throw up out the window, because you just can't drive and make it there if you don't. You want to get to the city because you're actually going to get something approaching a reasonable deal. If you can get to the city, maybe you're only paying $5 or $10 for 1/10 of a gram of heroin. Let's say you need about 1/2 gram a day just to stay well. That means you're getting out only $50, whereas if you're staying in town, you might be paying $20 or more for that same 1/10 of a gram. So you finally get a hold of one of your friends after you've been texting with them for a couple hours. They've got a little bit of money to kick in, you've got a little bit of money to kick in. Now you've got to find your third friend who is the car that works, and you meet up with them. Takes you another hour to find them because they've got their own things to do. They can't drive because their license expired, so you're the one driving. You make your trip 2 hours to the city. You wait around an hour waiting for your connect. They show up. Luckily, they give you what you asked for. You hand over the money. You use before you get in the car to come back, because again, you're going to be sick if you don't. And you drive back, hoping not to get pulled over by the highway patrol. By the time you get back, people have already heard you're coming back, so your phone's immediately getting blown up. People want to buy from you. People want to buy from you. All you want to do is go home and rest, because you've spent your entire day just trying to find heroin. And you spent probably $100 or more between gas, what you bought, and everything else. So you go home, turn off your phone, you get well, you spend the rest of the evening just trying to relax. That's a whole day out of your life. The heroin that you bought is probably going to last you 2 days. So as soon as you get home, you start thinking about how you're going to make it to the city day after tomorrow to do the same thing all over again. Now, that's not everyone's reality, It's a lot of people's reality. If you're far away from services, if you're far away from the methadone clinic, you're probably also far away from someone who can consistently sell you the drugs that you need. And it's not like you want to live this way. You'd love to stop using. You've tried before, you've tried to quit, but you can't do it on your own. You've gone to the local MAP provider, there's one in your town. They've said, no, I don't have a slot for you, sorry. Just stay strong, come back in a few weeks, maybe we'll have a place for you. You know, the nearest residential program is 2.5 hours away. All you've got maybe is a group that you can go to in town. And that's nice and all, but you don't want to be seen on the street because guess what? The cops are also looking for you. So it's really, 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 really difficult for this person to make it to appointments, to get to the doctor, to get to any kind of service provider because their life is on the one hand organized around the process of staying well, something that we all want to do. And on the other hand, around the sort of constraints and the fear that follow them everywhere they go in their town. So this is kind of how I sum up that experience. The first priority for someone who's dependent on opioids is always avoiding withdrawal, no matter where you live. Because if you're in withdrawal, then you can't do anything else. And people talk about that as staying well. And I think it's important that we recognize that people use that language and why they use it. You're dealing with distance, scarcity, and uncertainty in your supply, which means that you're spending most of your life just trying to stay well. And this is way more of a problem out here than it is in urban areas. And when you try to seek help, a combination of your own personal insecurity as well as the stigma and the lack of services available locally, not only make it harder for you to quit, but make whatever drug use you're engaging in more risky. So that's just sort of the baseline of what we're talking about. And stepping back, these are some of the other things that we just know are impacting people's ability to, reach the healthy outcomes that they want. People are isolated, they don't have access to harm reduction in the meantime. They've been cut off from their pills oftentimes from providers in ways that are unsafe, so too quickly and without access to alternatives. The treatment programs that are available don't serve them well. I've heard of programs that won't take people on MAT. They won't take people who have a history of failing out of other programs. They have limited slots, all those things. And so jail is maybe the only way for you to access treatment in your community, because maybe there's a grant or something that'll fund a few people who are involved in the criminal justice system to get services. But going to jail is maybe the most painful thing that you can possibly imagine, because what that means is that you're going to go through detox without any support. And you're probably going to spend hours or maybe even days lying in a holding cell feeling totally, totally awful before you even get that chance to get those services. And then the last thing, which I think is really important to keep in mind, is just the role of gossip, the role of interpersonal relationships in small communities. So people use the phrase small town shit with me all the time. They basically mean the fact that everyone is in everyone else's business. They can't go anywhere. They can't do anything without word of that getting back to the cops and getting back to the people that they don't want to hear from. So all of these factors, I think the big takeaway is that to reach people in communities like these, services have to be very low threshold, maybe even more so than in urban areas. So I wanted to talk about a few sort of buckets of strategies that you might use to make those services available if they aren't available in your community, keeping in mind those principles of making services really low threshold and easy to access. And so the three, I think, are kind of arrayed along a continuum of change, readiness to change maybe. So on the one hand, I want to talk for a couple minutes about partnering with existing services, the ways that you can take advantage of the things that are already happening in nearby jurisdictions if you don't have the resources to do them yourselves. The second thing is interim measures to reduce harm and support health among people in your community who are going through some of the circumstances that I described. And then the third thing is how, when you're actually ready to provide those services, some of the principles to keep in mind when translating them from urban to more rural or remote places. And this is sort of a new way for me to organize my thoughts. This is like one of the things I want to get feedback from you as to whether this is helpful or not. And if it's not, that's also great feedback. So there are a lot of different partnerships happening in California right now, which I think are great, or can be great, but really just serve as potential vehicles to do all these things. So I'm sure a lot of you are aware of all of them, and I don't need to lecture you on things that you already know. Just want to bring them up if they haven't been fresh in your mind. So you see the map of the opioid coalitions all across California. Many of you probably participated in them already. they're highly variable. So some of them don't do a whole lot. Some of them do a lot. If you are in a place where your opioid coalition isn't doing a lot, and there isn't a lot of buy-in and engagement, you could take over that coalition to do things that actually need to get done. That can be a vehicle for funding, it can be a vehicle for collaboration, it can be a way to force people into a room together to have a conversation about something that otherwise they might not be willing to have. Other services involve partnering with maybe individual providers in other places. So Plumas County has a great program, which I'm afraid they're actually doing. Is this the pharmacy breakout session as well, or is that the next one? It's probably the next one. I think it's the next one. So you can actually go to it if you'd like. Drawing on the experience of people in urban areas to teach or communicate with providers in rural areas about ways that they can improve their work. So academic detailing, going to pharmacists and providers to educate them on safer prescribing and harm reduction practices, teleservices not only around disease prevention like we're familiar with, but I'm really interested in talking about teleservices around treatment for disease as well as for substance use disorder. There's a great model of providing treatment directly at a syringe exchange in Mendocino for Hep C that Libby's involved with, and the provider who does that, I've also heard speak really amazingly about how she can work with remote communities to provide those services as well. And facilitating access among your residents to regional services. So, urban harm reduction services, we're already serving folks who live in small communities. So I help run the Needle Exchange in Berkeley. There are groups of people that drive from Stockton, from Modesto, from Vallejo, from Grass Valley, all up and down the I-80 corridor. They come to us because they don't have services locally. And we load them up with everything they need to go back to their communities and do underground needle exchange in their towns. So I think something to do in the meantime is make their lives easier. So if you can find those people that are already doing that work, anything you can make it easier for them to access services, advertise the services in nearby cities. Have conversations with your patients and clients about how they could access them. See if you could find ways to fund their transportation. Try to make the trip more onerous. Try to let law enforcement know that people might be doing this life-saving work in their community. Anything you can do to make it easier for people to access the services that already exist, it's going to facilitate them doing life-saving work in the meantime. So there are a lot of things that you can do in the meantime that don't involve starting a syringe program or starting a naloxone program or starting an MAT program that might seem really scary, but there are things you can do in the meantime and conversations you can have in the meantime that'll reduce harm and help people live their lives a little bit easier so that they can do what they need to do to stay healthy. What I just mentioned, informal services. So there's likely an underground needle exchange already going in all of your communities. That's hard work. It's unpaid, it's unappreciated, but it saves lives. It's how harm reduction got started everywhere that it did pretty much. It's very rare that it was public health that took the lead and started the first harm reduction program in a place. So if you can find those people, connect with them, find ways to help them do their work better, I'm happy to talk about any of that in more detail. But I do want to get to the part where we hear your questions. That's a great thing that you can do. I'm in touch with people running underground needle exchanges in a couple of different counties. They've actually had some success working with their local health departments to do, kind of more modest things to support them that don't involve the public health department actually giving out needles. So it is possible. Another big thing that I touched on in the panel discussion is law enforcement priorities. So law enforcement is a real challenge to people's health in a lot of communities. The things they need to stay safe are also things that are technically illegal. Law enforcement is often, if they don't have a way to arrest someone, a paraphernalia charge, possession charge, being under the influence, those are all easy ways to get someone that you want in jail. It's also a really easy way to put people at risk for infection and other health problems. So having a conversation with your law enforcement about, what is the community value of arresting people for having a syringe on them? Like, what are we actually getting from that? If that person really needs to be in jail, is there something else you can arrest them for that might actually be a substantial crime? Or if you're doing probation checks and someone has clean needles in their house, do you really need to take them? Maybe you should talk to them about why they have them. Maybe they have friends that need them. Is it really more safe for you to do your job if you're taking the clean supplies from people? So if you're searching people, you might get stuck with something that's not clean, And just something that I want to highlight in this kind of bucket is that something that's happening a lot in places that don't have adequate access to treatment is that the people that can get Suboxone, they help their friends out with it. The reason that people give Suboxone strips or Subutex tablets to their friends is because their friends want to get well in a safe way. Using buprenorphine is safer than trying to find heroin. Saves them money, saves them time, makes it easier for them to do other things in their lives that are going to support their health. And so viewing bupe diversion, not as a crime, but as an incremental step towards getting people to access more formal treatment, I think is a really important interim step and something that some law enforcement departments across the country have already publicly said, hey, we're not going to prosecute someone for bupe possession without a prescription. And just in the incremental, following on that line of incremental change, if you can't give people needles, at least give them a way to get rid of them. So whether through your opioid coalitions, through the hub and spoke systems I've heard, calling up and asking public health departments in larger places if they have any extra bins lying around that they could share, if they know where you could get some easily, having a place for people to dispose of syringes is going to keep them safe and also get them used to working with you around their drug use. So this is a Sharps bin that's operating. This is up in Modoc County. This is right outside the Health Services Department. These bins contain needles that were used to inject illicit drugs, and they're being disposed of properly. That bin is being used, even though it's right outside the door of the health department. Another important incremental thing, looking at the treatment side, medication-assisted treatment is typically thought of as a combination of medication and psychosocial counseling. And that's really important that people, if they need that mental health support, that they have it. But there's actually a lot of evidence, like lots of evidence, a surprising amount of evidence, that just giving people medication with no counseling is still effective on a lot of measures. So it keeps them safe, keeps them engaged, it's easier for them to access if they can't make counseling appointments. It's a way to build that conversation with people around other aspects of their drug use. And so if you have a provider who wants to prescribe buprenorphine, but you don't have a full counseling staff, giving that person a prescription for buprenorphine is going to be safer than not. Okay, so, and if you actually want to take the step of starting these programs yourself in kind of a full-fledged way, just a couple of things I think need to be kept in mind is reducing barriers. So I don't know, I think it was Libby that on the panel said, the problems aren't different, it's just that you have to approach them differently in different communities. And so these principles of reducing barriers and adapting program designs, those are the same principles we use in the city, but they look different in a remote community. So if you live in a dispersed, outlying area, reducing barriers might mean going directly to where people are rather than expecting them to come into an office. Doing deliveries and home-based services where they don't have to show their face on the street. Doing them in an unmarked vehicle so they don't have to be associated with the public health department. Those are ways to reduce barriers in an isolated community. Community integration, and by that I mean not keeping harm reduction separate from the other aspects of health services and of the community in general, but really making it a part of everyday life. Drug use is a part of everyday life. And I think it is counterproductive to treat it as something separate. So, I think about this all the time. Danny down in Sierra County, one of the places that he was advertising his naloxone distribution program was at the town dump, at the general store, at the places where people in small towns gather. If you don't have a needle exchange, if you don't have a treatment program, if you don't have a public health clinic, right there in town, then you might think, oh, there's nowhere for us to advertise and reach people. No, people are still out living their lives. You just have to figure out what those places are and reach them there. And when it comes to adapting program design, similarly, so reaching isolated groups, both physically isolated and socially isolated. So people who live in places like this, who might be far outside of town, who might be literally in the dark, who might be living, in mud, going there, seeing them there, doing outreach there. It's very powerful. And the last thing I'd mention around privacy and confidentiality, this was an interesting sort of wake-up call for me a few years ago when I went to a harm reduction conference and heard from folks who do harm reduction in rural New Mexico. So in very isolated small communities in northern New Mexico, where they can't show up in a little town and park their van on the street corner like we do in Berkeley and have people come up to their van and get their needles and walk off. that works in Berkeley because there are people around all the time, and so there's a sort of public anonymity there, where you can be on the street and not be identified immediately. And a lot of the folks that we see live on the streets, so it's no problem for them to come to the van. If you're in a small town, rather than sort of the public anonymity of a city, maybe you want the private confidentiality of a face-to-face interaction, not in the town center, but hey, at this tree that we both know outside of town where we can meet, or at down by the riverbed where people gather, someplace where you can reach out to the people that you need to meet directly to maintain their privacy and confidentiality. So in Berkeley, we don't really like to know people's names. We prefer not to know people's names. Like, we know them as the people that come every week and we talk about things, but we don't want to know people's names because then if the cops come and ask us, we don't know who they are. In a remote community, you want to know people's names and you want to have their cell phone numbers. You want to know where they might hang out, where you can find them. So thinking about how you can reach people might involve a few sort of different practical considerations than in an urban area. Okay, great. I think I have one more slide. Yep. So just a few takeaways. I know I said a lot of things, and I'm excited to hear what you have to say. People who use opioids want to be healthy, but health means different things at different stages of a person's life. Getting well is part of the process of seeking health. So staying well in terms of using the drugs that people need to use that they're dependent on is kind of a precondition for them engaging in other health services and doing other pro-social and pro-health activities. So keeping that in mind is important. Because of the overwhelming need of people to stay well, for them to access services, those services need to be both more accessible and more appealing to them than staying well on the black market. So, black tar heroin, it's gross. It's not something that you really want to use. It's like a bad product. But it's what people are forced to use because it's all they can buy in California to stay well. So the fact that people are still willing to go back to the black tar and to do everything they have to do to get it is a sign of how difficult it is for them to access any other services and how unappealing those services are. And so the takeaway for program design is that you need to partner with people who use opioids from the beginning so that you can avoid, the misunderstandings, you can avoid putting a lot of work into protocols that aren't going to work, so that you can, actually learn what are the primary constraints on people accessing our services from the beginning. And there are a few models to do that as well. So, here in Plumas County, they held some focus groups with people in the jail who use drugs. That was a great way to meet some folks. There are other ways to meet people in the community to get those, really honest and candid feedback on what they need to stay healthy. So that's about it. Thank you very much, everyone. I'm really looking forward to And so I didn't have any grand scheme of how I was going to organize the second half of this, but maybe I can just sort of get some reactions and we can go from there. Stephanie,
David,
can you introduce yourself also, just for the people in the room when you start talking?
Stephanie Tanaka from this County Alternative Sentencing. Can you talk a little bit about the diversion and what you're hearing from individuals who divert to their friends and what the likelihood is that they share with you that they engage in further treatment or access to treatment on their own? Because I know you do have some information on that.
Yeah, so from what I've observed, the typical situation where someone shares their puke is that they're hanging out with their friend and their friend is sick and they don't want their friend to be sick anymore. And by sick, I mean their friend is throwing up and their nose is running and they're having terrible hot and cold flashes and they're just a mess. And so it's really it's an act of empathy to give people that medication under those circumstances, usually. The way that people use their buprenorphine is it's really it's not one size fits all. So a lot of people, they know whether they're ready to stop using or not. People talk all the time. You have to be ready to quit. That I don't think I'm quite ready. I'm getting there. I wasn't a year ago. Now I'm closer. And having some bup on hand, some Suboxone on hand, helps them on the days when they're like, hey, maybe I want to quit. And they try and then they can't. Having that Suboxone to fall back on is a really safe way for them to practice reducing their use. And practically speaking, if they aren't ready to quit, but you can't get heroin that day, then keeping a Suboxone in your back pocket is a way for you to go about your day normally, even if you aren't intending to engage in further treatment. And I think that engaging with people at every stage of that spectrum is important, because every one of those actions is moving closer to health. You know, it's just that they're starting from different points. I don't know if that directly goes to your question.
Yeah, thank you.
Yeah.
Well, just to follow up on that, so.
Where are you from? What's your name?
Sorry, Lisa from Safe RX Lake County. So, I had another question, but just talking about the youth diversion. So somebody's getting a prescription, they're in MAT treatment, and they have a prescription for so many pills, so they're giving some to somebody else, so now they're coming up short, and they have to go back to their prescriber and say, I need more, and then the prescriber says,
Why? Yeah. So I mean, if the prescriber is, you know, understands why they might have given their Suboxone away, then they won't discontinue them from treatment. And I know providers who understand that their patients are diverting, and they might not say this in a public setting, but they understand why, and that's not for them a reason to kick someone out of treatment. And I think working with people, well, it's like, you know, maybe the next step of the conversation is, okay, you're helping out your friends, that's great. How can we help them more? Like, why aren't they coming in to see me and get their own prescriptions? Like, is it because of me? Is there something about me or my program that's keeping them away? And how can I change that? So I think that, you know, viewing that not as the end of the conversation, but as like the beginning of a different conversation, when the patient comes back and is short, I hope that that's the attitude that some providers will take. Is that a hand in the front?
Yes, I wanted to talk about structural barriers,
Yeah.
systems barriers.
Where are you
So
from?
I'm Lisa Lee from an integrated opioid treatment and recovery center. We offer medication-assisted recovery in northern Nevada, so we service like 7 rural counties. Our barrier, so initially, you know, we were recipients of the what you're calling the hub and spoke grant, the STR funds, and we wanted to expand services, mobile, methadone and Subutex services in our vans, which we have, and things like that, like innovative strategies to improve access and reduce barriers in the rurals are prohibited by larger entities that sort of have the final say on what we do out there, right? I mean, I'll say like the DEA is kind of the scary. Don't want to be on their bad side. I think I've been there before in my past, but so like there are systemic things that I think we really need to talk about. It's not the people we serve that provide barriers, it's these larger systems that really kind of inhibit our ability to be innovative and have strategies that could really truly solve problems. So I was just hoping to hear some pointers from other folks. I mean, our solution, we're so determined and stubborn that our solution was to open up an NTP versus an OTP, so a narcotics treatment program, which is just dispensing. It's just a dispensing clinic. Out in the rurals, we partnered with another entity, and we've done a lot with coalition building and all that, but that was our like FU DEA. We're going to provide services out in the rurals anyway, just not in our vans. We just get rides in our vans, but.
Yeah, you know, there's a story from Santa Clara County in the 90s, back when needle exchange was still illegal. So the Santa Clara Public Health Agency was actually running the syringe exchange program. They had locally authorized it in contravening state law, and the California Attorney General, Dan Lundgren, threatened to sue the county and sue all the supervisors personally, civilly and criminally, for supporting the program. And so the supervisors were like, this is awful, like we can't believe you're doing this, but we don't want to go to jail, so we'll shut down the program, okay? A week later, a different group of people, not identifying themselves as county employees, showed up in the same spot and did needle exchange with a county employee parked just down the block, offering disease testing and all the other things that are still legal. Now, who are those volunteers that were doing that? I have no idea, right? But the reality is that we can do a lot of things in our private lives that maybe we can't do on payroll.
Right.
And that actually doing that stuff, that volunteer work, is going to make your programs better if you actually can start them formally. So. Yeah.
My name's Elizabeth Brunton, and I work for Plumas County Behavioral Health. Just about a year and a half ago, we opened up wellness centers in outlying areas, Chester, Greenville. Those wellness centers not only have partnered with and do needle exchange, we provide blankets, food, clothing, kids' books, yoga classes, showers, laundry facilities, anything that anybody possibly could need with no questions asked. And we do that on a county level with partnering with probation. With every other county department. James brings his van, the needle exchange, people show up. It's only a year and a half in. We're still a little bit newer with a lot of these things, but I really wanted to share that because I feel like it's made a big difference in stigma reduction. We don't know who comes in that door. They sign in and they say what service, but they could say any name they want. All we need to know is what services does that community want so that we can build on those programs. I think so far it's been a big asset for Plumas County, and it's more and more and more people are showing up, the more their departments partnering with us.
Yeah, and I think go ahead.
I was gonna say, it seems to be working in a community like this, at least getting people out.
And I think that really illustrates what Rachel was talking about in the opening panel, that sometimes the things people need to stay healthy don't seem like health resources.
They can get free food, jackets, jeans,
in Berkeley,
you name it.
in Berkeley, one of the most popular things we give out is socks.
Yes.
Yeah, absolutely.
Yes.
And people come to us because they heard we have socks.
Mm-hmm.
Or we give out Band-Aids, antibiotic ointment, razors, all those things that aren't directly related to preventing the spread of injection-related HIV and hepatitis C, but that get the people who, also need those services or who are also facing those risks to come to us, and we learn from them what they need. And that impacts our services. It's not like we've always given out socks, but we're like, hey, we could do this, and it's clear that people need them. And having wet feet, cold feet, numb feet, whatever else is going to keep you from getting to where you need to go and doing other things too.
James has also come around and we also have Narcan in all of the centers. And every single person is trained to at least talk to that person that wants to take it. So
Great.
we're trying.
Yeah.
So one of the things that I think, I come from a grassroots perspective, not necessarily just in this field, but all around. And one of the things that I think is important to keep in mind as this grows from the fringes to being more popular is tending to those grassroots. And so just kind of hearing what some perspectives in the room might be as to how we don't let it outgrow those on the fringes. And I think one strategy is peer support.
Can you say what you mean by that?
By peer support or by, keeping people at the table who are impacted, I think is really important. And then as far as on the spectrum, from chaos to abstinence, having people all along that spectrum as providers, I think is really important.
Yeah. No, I totally agree. And building space for, paid positions, actually,
Yes.
if you can provide them,
Yes.
paid positions for people who use drugs, because one of the things that's facing people who use drugs is they don't have income oftentimes. They
Right.
don't have good sources of income. So giving them an income is going to help them do good work, in your office and out of your office. But volunteer positions, a community advisory board that's actually made up of people who use drugs and not just service providers, and not just people who used to use drugs, but people who are actively using drugs, which might not, which isn't just who you think it is. Like, there are lots of people in your communities who are using drugs and have that experience, and finding ways to get them at the table is only going to make your programs better over the long term. Dawn, you have your hand up?
David, is there any other organizations or communities that are using active users on their word other than Hatcher?
Other than Hatcher, oh, okay, well that's an important caveat. Yeah, because we've got Brandy in the back from Hatcher in Humboldt County, which is really one of the leaders in California doing it that way.
Are they sharing? Because that's kind of the first time that I've heard actually that that has been happening.
Sharing about that experience, you mean? Well, I mean, I'm sure that she would share with anyone who went up to talk to her afterwards. But yeah, I mean, I think that's, in San Francisco, they do a lot of peer-based exchange. Again, a place that's had harm reduction for a long time and has a very close-knit community of people who use drugs. That might not be the case everywhere. I think really like Hatcher's the model right now for me in terms of how to reach people in remote areas. And I think that new programs coming online, building that in from the beginning, is really important. So
it's really difficult to get your clients, the active users, to trust you.
Yeah.
To engage in services.
Mm-hmm.
You know, it's a new service in our area, and having them trust is huge.
And it might make your program more controversial.
Yep.
That doesn't mean it's it's not the right thing to do. Can I go to the new hand in the back? No.
I had a question related to that, just if people have concrete examples, like how do you begin that? We have a relatively new program in Monterey County where there's been a lot of instability around syringe access, like organizations, going out of business unexpectedly, leaving, HIV organizations going out of business. The county doing questionable things, just there's been reason for the client base to potentially mistrust service providers, and I think that we're doing a pretty good job. We've been there for 3 years now of like building that in from the beginning. But one of the things I'm kind of here to learn is like what else can we be doing, whether formally or informally, because I think we're doing a lot of informal things of having the conversations with clients and just trying to be engaged and interested in the situations that they're living in, finding out what they need. We haven't been doing things like focus groups or formal interviews. I would like to move towards that, but like, what do people have kind of thoughts on like how do you engage folks from the beginning, especially like referring back to something that I think Brandy said in the opening thing of like that idea that like people who use drugs, like nobody wants to hear from them. And when that idea has been like internalized by the community itself, and that even the drug users kind of feel like nobody wants to hear from them, like I feel like that's something that we're confronted with.
I would love to hear other people's responses to that question.
I'm sorry, I'm Clarissa. I'm from Butte County, but I want to piggyback on what you just said. I'm doing working in a clinic with pain control patients that are kind of accidentally falling into opiate addiction. It's kind of odd. I live in a weird place, but anyway, there's a lot of judgment within the drug using community about who's using what. And so I'm afraid to treat that, you use oxy, I use meth, and there's this weird hierarchy in the drug world. So I want to be really careful in my small community not to bring the wrong. I think that's some weird.
No, it's reality.
In terms of a barrier to harm reduction, like the 12-step community is really, the whole abstinence base, which is phenomenal. But, we were talking about kind of the rural communities with law enforcement and enforcement supervisors and those structures maybe being resistant to a harm reduction model. But it's also people who are abstinence-based recovery folks. And so you're kind of in the middle of that. And then you have, like in our area, really people unexpectedly opioid addicts.
Right.
But that's a huge to the rest of the community because people are seeing, oh my God, my nephew, is an addict, or my neighbor, and they got hurt, and then they're like this. And so it actually builds the empathy. So it's like, the people who are at the table, why are they there? Right? Anybody. What's the issue? What's important to you as to you as to you could be 3 different things, but we need to know what each of those things are so you can stay at the table. So we're talking about our relationship and what we're trying to do together to make whichever issue better.
Yeah, and the one thing I'd add to that is that, recognizing that not all people who use opioids are addicted to them, even people who are using them non-medically. And that if we assume that what people who are using opioids need at the end of the day is treatment, then that itself is going to be a barrier to harm reduction. So recognizing that actually, like, the person coming to you because they need needles, you know, they could have their life totally under control except for the needle issue, or they could have a whole lot of other issues going on. And you can't know which sort of side they're going to fall on until you talk to them. And designing services to reach people at all points on that spectrum is really important. So, yeah, Lisa.
I had a comment to address what you had said and then a question. I think incentivizing people to share their voice and offering a space. So like in my outside of work life, I run a writing group for people experiencing homelessness that's recovery focused, wherever they are on that continuum and however they interpret recovery, self-determination, self-efficacy, all of that. And finding, number one, an outlet for self-expression and supporting that space. It takes a lot of work, but it's totally worth it. Number two, finding funding to incentivize their telling, like giving value to their voice, and also showing by example that the best way to fight stigma is openly disclosing loudly and proudly. Mm-hmm. So there's some modeling, and then there's monetary incentivization programs that I think will really enhance bringing people to share their experiences and share their kind of what they are currently doing. And the second thing is related to a question. So I come from Nevada. I'm on the peer certification state board. We have, sort of formalized that in our state, and I'm wondering if you all have done that, because that is another incentive for organizations to offer paid positions for people in the trenches, people still experiencing that. And it is Medicaid reimbursable, that peer-to-peer service. So I'm wondering what the pulse is here in California versus in Nevada, where it's really kind of a thing.
I can tell you.
Mm-hmm.
So we do have peer advocates in the wellness centers. California has not accepted the certification piece yet, but it's about this close. We have 4 peer advocates currently, and we're hoping to be able to bring on 4 more. And we put them through the WISE-U program at this point, which you've probably heard of. It's in Sacramento, and it's 70 hours. So we have started embracing that. They're amazing, so much fun, and they do get paid to work in the centers. That certification, like I said, is this far, and then it will be Medi-Cal refundable, or for their services.
Good deal.
So we're real close.
Yeah, what I would say about that is, like, an important part of this is reassessing what counts as expertise. So the real experts on these issues are the people that are using drugs, because oftentimes they're the ones who are already doing harm reduction for you, essentially, in the community. And recognizing that expertise, isn't freely given. People have busy lives, and finding a way to compensate and recognize them for lending that expertise. When I do interviews, it's common for people to say, I give them a little bit of money for their time, but just the experience of having someone actually listen to them and like genuinely say, hey, I'm gonna try to do something about what you told me is powerful, and maybe they've never experienced that before at all. I saw that Stephanie had her hand up in the back, and then we can come back up.
I did, and it's really just to kind of, and Zach and David can speak way better to this than I, so if I'm misspeaking, or if you want to jump in, please do. But part of the way that we gained so much traction in Plumas County is not only because we were #1 on opioid overdose deaths in 2015, but through our public health initiative and through their community health improvement plan and that process. Our public health agency and all of the staff that work there really did an outstanding job of garnering community support and pulling everyone together from all different walks of life and agencies and within the community. And so if you're struggling or if you want assistance, my suggestion would be to reach out to your public health partners, because that's really how we gained a lot of traction within Plumas County, and specifically for us within the criminal justice system. We all wear so many hats in rural towns and rural places, but having an agency that has the expertise and the wherewithal to know how to do a focus group within the jail to not, create more issues within our inmate population, and be able to translate outside so that we can start an naloxone program in our jail and do all of those things. So if you're looking for guidance or resources on how to gauge people's willingness or what they need, I would say reach out to public health and utilize their community health improvement plan and the process that they do for community engagement. So.
Thanks. Yeah, I saw a hand up front.
Yeah, I kind of wanted to build off of the drug hierarchy, if you will.
Yeah.
Just because every day we're all from different social classes that we're all working together as it is. So I think it might be a little futuristic, but in a sense we could probably mix those cultures all together, and it wouldn't be anything you blink an eye at like we are now, all working together from poverty all the way up to high, upper class, all working together in the same places. And then when you add the value to what the person is doing, so like these people that are trying to reach out for help and stuff, that want to make changes, when they actually value what they're doing and influencing other lives, it's so much more impactful than just a job, so to speak. And I've kind of witnessed that myself, just going into a career choice because it was available, whereas I'm still volunteer and I miss volunteer because I love what I'm doing. So it just adds that whole other perspective when you really see the value in what you're doing.
Thank you. I think we have time for like one more question. Yeah, in the back, Rachel.
Hi, so I just wanted to respond in terms of building trust. My experience, at least in the outreach, was just starting out by offering people just like a granola bar and not asking their name, not having any expectations at all, and like for maybe 3 months, like literally just say, hey, you want a granola bar? And there's no expectation that they're going to tell you their name, that they're going to trust you, that they're going to like you, that they're going to want to talk to you for more than 1 second. And then the other piece I think is just sort of showing up and being consistent is like really important, because a lot of people come from major trauma in multiple aspects of their lives where they didn't have family members that they could trust, or they had family members who actively violated their trust. I know in San Francisco, in a different context, the Food Not Bombs was trying to figure out how to build solidarity across like a multiracial coalition for social justice, and they worked with day laborers in the Latino community, many of whom are undocumented and are really afraid of outside groups, and they just showed up every day and brought food and didn't ask any questions and just sort of decide like, how can I be helpful? And at first people thought, oh, it's just a bunch of well-meaning white girls, they don't know what they're talking about, and then eventually that trust was built and people did coalition building, and it just takes time and consistency and not having expectations and having it not be about you, basically.
Yeah. Thank you, Rachel. And just to kind of wrap this up, I'll take this speaker's privilege of saying one more thing, which is that, the history of harm reduction has often been led by essentially like non-governmental leftist street protest groups and groups of criminalized people. That's how harm reduction got started in the cities, was people in those groups mobilizing to save their own lives and the lives of the people that they love. There aren't a whole lot of leftist street protest groups in rural Northern California. If you go to Fresno, you can find some. But if those groups aren't around, then you and the public health agencies have to be those groups, essentially. And if your clients are criminalized, then you have to think like you're their accomplices in health, basically. And if you don't sort of go down to that level and think about, okay, what do they really need, given the fact that everything they do is illegal, basically, when they're out and about using drugs, how does that change the way that I approach my work as a public health worker, broadly defined? So that's sort of what I would leave you with, is that oftentimes harm reduction work needs to feel more like accomplice work than it does like bureaucrat work. Thanks for coming.
Thank you all. That was a great conversation. Lunch is being served in the Dame Shirley Plaza, which is the park. If you exit